All right. Good evening, everyone. Once again, thanks for joining us on our bi-weekly sessions. Dr. Mankat, good evening. Aigen, hello. Dr. Vijay, thanks for joining.
Hi, good evening.
All right. So we have 7 cases. We'll start off with 5 cases from the Rainbow Group. I hope the presenters are...
So going further, I won't be able to give you that.
All right. Kindly limit the background noises. So we'll have brief clinical and imaging discussion followed by differentials. If you have proven cases, we'll try to match the phenotypical findings of the cases. We'll try to limit the case discussion for about 10 to 12 minutes to keep on time. And the chat is open for any further comments and opinions. So with further ado, we'll start off with our first case. Hopefully, Geeta is there. Geeta, over to you.
Yes. So this child is a male child. He presented to us around 2 months of age. So there is a significant perinatal innocence, born to 4th degree consanguineous parents. And for first 1 week, he was fine, cried immediately after birth. Later on, from 1 week of age, what the parents have noticed was there was always constant fisting, noisy breathing, and the stiffness of the whole body. Sometimes apneas and shivering of the whole body was there, and the feeding was okay. And child did not attain any milestones yet. There is also significant history of previous sibling, that is a male sibling, death around 2 months of age. This sibling had a different phenotype in the form of like poor fetal movements, and overall there was a weak cry after birth, but he was always dull, poor feeding, poor bodily movements, and was loose to handle, in a sense like tonal issues, and had sudden death at 2 months of age. The cause of the death was not known. So on examination, there was a significant microcephaly, sutural ridging was there. There was a dysmorphism, generalized spasticity, and significant touch-induced startles were there with poor habituation. Other systemic examination was showing a supraglottic retraction, stridor, and poor perception of light. So from the clinical point of view, we had a diagnosis of like developmental delay, generalized spasticity and all. This is a clinical images which showing the dysmorphism in the form of sloping forehead, stubby nose, long philtrum, thin lips, and also retrognathia. There is also a video.
Video I didn't get.
Okay, so all the video was demonstrating the startles, like with the touch injuries, there was significant startles with poor habituation. So clinically, we thought that any glycine cleavage system issues, but with the background of dysmorphism, primary startle syndrome, it is rare. So we were thinking any non-ketotic hyperglycemia and all. So we didn't do any much investigations. Only EEG was done, which was showing a discontinuous pattern with multifocal spikes. We want to go further with after the MRI discussion.
Okay. So I have only external images. The child at 2 months of age. Only limited sections here. The coronal sequence over here on the T2-weighted sequence. I have zoomed in images of the main findings. You can appreciate there are some T2 hyperintense foci in the deep brain nuclei out there along the thalami. The child was a preterm or term, Geeta?
Child was a term baby.
Okay. So yeah, the main findings were actually over here in the central regions of the brain. Not sure if you can term it as simplified gyral pattern. You can see there is some gyration simplification along the frontal lobes out there, the temporal lobes. Again, very pixelated images of the T1 weighted sequences. Again, the main findings here are the thalamic hyperintensities. Other than that, I cannot appreciate any other finding. Diffusion, again, not optimal, but the typical findings of the pyramidal tracts or central white matter changes of suspected NKH is not seen over here, at least on these images. SW, I cannot appreciate any mineralization or hemorrhage. I don't have a SAG to look at the corpus callosum. But yeah, these were the main imaging findings, and I couldn't put together what the imaging findings could suggest. Maybe depend on the clinical handles more than the imaging findings on this case. So I'll open the case if anyone has to and further comments. I've seen someone in the chat. Sridhar has mentioned Krabbe's interphenolopathies, mitochondrial disorders based on the clinical presentation.
I have some comment, if I'm allowed to say something, Nihaal.
Yes,
Just from the history, I mean, non-ketotic hypoglycemia does not present with microcephaly at birth. If you have stiffness at birth, you can say this is either a special syndrome or a prenatal damage which occurred at least 3 weeks earlier. And there is a condition in the literature called symmetric thalamic lesions, acquired. Often in the history, you have a loss of fetal movement temporarily, and the babies are born stiff and often with contractures. And this I would consider as top on the list. So an acquired condition. And in imaging very early can be quite, let's say, disappointing. But later on, you see findings in the thalami and also often in the brainstem.
Got it. Thanks again. There's a comment on BRAT1 mutation. I'm not sure of the imaging findings of BRAT1 if it matches clinically. So I think
I'm
Geeta,
just impressed by the stiffness at birth. This is unusual.
Yeah, the stiffness was there, like they observed from the 1 week, and it is very significant stiffness. Almost the child is in a going into the posturing because of the stiffness.
Sorry, Nihaal, I had a call. I couldn't completely. Do you have a confirmed mutation that people are discussing in the
No.
chat? Or?
Clinically, they were suspecting NKH, but it doesn't look like NKH at least.
All right, because somebody's talking about BRAT1 and all that. So this child has got microcephaly, right? Or at least on the pictures, it looks like it.
Yeah.
And in terms of the brain, you would agree that the subcortical white matter lesions are quite prominent in the temporal lobes as well, particularly when, yeah, those pictures there, exactly. That may be a slight handle or not. I thought the folding of the brain was normal.
All right.
A bit odd in parts. I agree what you're saying, but you have only these snapshots, so we can't say more. But it has folded itself. We don't have any obvious pachygyria or lissencephaly or polymicrogyria.
No.
And then you're left with these, would you call these perivascular spaces, or do you want to call them infarcts in the middle? It's hard, I know, because we don't have the right.
I would say more of infarcts.
Yeah.
Is that the usual location of PDS in a neonate?
It can be. I mean, I think they're prominent even if they are just PVS. Yeah. But the discussions around the subcortical temporal white matter changes, that could help you a little bit with the differentials, including, I quite agree with whoever has put tRNA defects and things like that. You might want to even screen for AGS, for instance, if we are construing that these central lesions could represent ischemia. Yeah. Then Ikari-Gutierrez could be a differential as well in the spectrum. But I think we have to go down that list of small differentials we have for temporal subcortical white matter changes, Nihaal.
Yeah. Geeta, is that fine? Are you sending for genetics by any chance?
Yeah, we'll plan. Okay. We haven't sent yet.
Okay. All right. Let us know if you get an answer.
Yeah, sure.
Thanks. All right. Our next case, Pituja.
Good morning, good evening, everyone. We have a 7-month-old female child born out of consanguineous marriage, with no postnatal complication, now presenting with developmental delay with epileptic spasms that was noted since 6 months of age, 1 month prior to presentation, and these spasms were in a cluster of at least 3 clusters per day. On examination, the head circumference was 40 centimeters. For this, it is at the borderline of the 3rd centile. Extraocular movements were full. There was good tracking, poor neck control, mild hypotonia. Vision and hearing was intact. And on skin manifestations, there was petechial rash, mucosal redness, and acrocyanosis that was evident. And then we went ahead with the imaging.
Yeah. So as this was, I think, 2 months back, we spoke to the parents today. They say that the rash and the mucosal redness has disappeared, and the acrocyanosis also is not visible at this stage. So it's kind of a transient changes of the skin lesions. These are the MRI changes on diffusion. You can appreciate central diffusion changes in the thalami out there, the fornix along the anterior commissure, the globus pallidus inferiorly, involving the brainstem structures and also some areas of the cerebellum on either side. On the D2 sequences, generalized atrophy of the supratemporal brain. You have these multifocal abnormalities now also involving the basal ganglia, which did not show restricted diffusion, along with the changes which showed diffusion changes on the previous slide, that is the thalami, the brainstem, and also the cerebellum. So additional changes are these spotty changes on the basal ganglia, predominantly the dorsal striatum, and these extensive areas of cortical volume reduction in the supratemporal brain. So on the midline sagittal, you can appreciate the thinning of the corpus callosum. The pons also possibly slightly hypoplastic. Again, you have these brainstem abnormalities along the hypothalamus. And on the SWS sequences, we did not appreciate any mineralization. Spectroscopy in the abnormal regions demonstrated a significantly elevated lactate peak. Based on that, the imaging differentials, which we thought of concentrating on the deep brain nuclei basal ganglia changes, these were the various possibilities to consider. ADEM was not considered, but the patchy abnormalities in basal ganglia can be seen in these disorders, along with the thiamine transporter deficiency disorders and the Leigh syndrome. Leigh syndrome slightly more confluent in comparison to our case. Some other imaging findings which was similar to our case was the Leigh syndrome, because this child clinically does not present like a Leigh syndrome, no kidney issues, no sensory or hearing loss, but the changes in the central region of brain can be similar. And also to be kept in mind is vigabatrin, which can also have the central diffusion changes. I think this child was then sent for genetics and Rituja, yeah.
The genetic report was showed uncertain significance of ETHE1 gene mutation at exon 3, which was autosomal recessive homozygous, since the phenotype is matching with the onset being in the first month of life, an autosomal recessive condition having acrocyanosis and the skin changes of petechiae with developmental delay and the MRI finding. So this was taken as a matching phenotype for this condition. So this was the case of ethylmalonic encephalopathy.
Yeah, just to point out, these are from literature. Petechial lesions are typical. The parents described them as mosquito bite type lesions in the legs, and acrocyanosis also can be seen in these conditions. So yeah, I'll open the case if anyone has any experience with these the disorder, and the treatment and prognosis for the child.
I think Sridhar has put things in the chat, which is quite useful. But
Yeah.
Are we headed in that direction already?
Liver transplant. Rituja, any idea how the child is doing?
Not of now. I think cancer is.
I see Dr. Vivek. Dr. Vivek, any experience with ethylmalonic? So NSY16, metronidazole, yeah, from Sridhar, as mentioned, and liver transplant. Okay, but I think we are matching the phenotype clinically and imaging wise that this is an ethylmalonic acidic case for encephalopathy. Okay.
I asked Sridhar a question. He said that even before you showed the images, he put the clinical diagnosis of ethylmalonic aciduria. What were the clinical features there? The acrocyanosis, right? Okay, you got that. Yeah.
I think that the clinical findings were a clincher for us. Yeah. Yep. All right. Thank you.
The next case is a 3-year-old male child born out of consanguineous marriage, presented with motor and speech delay, followed by motor regression from 2 years of age. On examination to us, he had mild intellectual delay, spasticity of the lower limbs, and aberrant Mongolian spots with hypertrichosis that was present. So scanning was done for this child, MRI scan.
All right. So we have axial T2s on top. You have these confirmed areas of white matter changes, somewhat like a demyelinating leukodystrophy out there, sparing the subcortical regions, periventricular and deep white matter predominant. The basal ganglia also slightly hyperintense. Coming to the ventrolateral thalami, the thalami do appear slightly small and dark on the T2 sequences, especially the anterolateral thalami. Coming inferiorly, brainstem appears normal. Cerebellum cannot appreciate any signal changes in the cerebellum. There is some degree of mild volume loss in the cerebral cortical surface and the some folial prominence in the cerebral hemispheres on both sides. On diffusion sequences, I cannot appreciate any abnormal signals on the diffusion scans. Midline sagittal sequence to better appreciate, you can see that the corpus callosum is also involved in the white matter abnormalities. Some degree of hyperintensity along the dorsal brainstem out there. Pons possibly is slightly hypoplastic here, and you can appreciate the folial prominence in the vermis, especially the anterior lobes. Optic nerves, not sure if you can call this as hypertrophic, but slightly prominent out there. The SWI did not demonstrate any mineralization or hemorrhage. And this is just a coronal sequence to demarcate the leukodystrophy pattern, some degree of atrophy in the cerebellum and also in the cortical regions of the frontal and parietal lobes out there. Given the imaging pattern, we think of leukodystrophies with the periventricular predominance. These are the differentials considered, MLD, Krabbe's, both primary considerations. Then we look at the deep brain nuclei, look at the dark thalami, and think of lysosomal disorders, which can present with white matter abnormalities and these dark deep brain nuclei changes. And the result, yeah, Mituja?
So the genetic report was showed a pathogenic variant of ARSA mutation at exon 2. It was an autosomal recessive homozygous mutation indicating metachromatic leukodystrophy. And this was a phenotype match with the autosomal recessive inheritance. And on juvenile onset, infantile to juvenile onset could be there with the muscle weakness and developmental delay and the characteristic MRI findings.
I have a clinical question, not very important. You mentioned spasticity. So if you have spasticity, you would expect hyperreflexia, but because in MLD you have also a peripheral neuropathy, this is a condition where you have spasticity on one side, but absent reflexes on the other side.
That's right. In ARSA, it's been mentioned that earlier part, they usually have hyporeflexia, whereas they develop hyperreflexia later on. So even though they have spasticity, maybe there was hyporeflexia in this child Dr. Shrikant has examined.
And hypertrichosis, is that common, Prituja? Or usually you think of mitochondria when you think of hypertrichosis?
It is not one of the phenotype that has been mentioned for ARSA, hypertrichosis.
Right. Okay, I don't see any comments, so that's the case of MLD. All right, next case, Anas, are you there?
Yes, sir.
It's just one point, Nihaal, if you go back to the imaging of that case.
The basal ganglia.
It's a lot of atrophy we see at baseline, right?
Yeah.
Already on this case.
The only thing was the basal ganglia slightly hyperintense, whether it comes up in later on state on MLDs.
Yeah. I'm just thinking whether we would have made an assessment of that based on the thalami, etc.
Because we call it as gangliosidosis and lysosomal, given the basal ganglia changes.
Okay, is that what it was called? Okay.
It was called, yeah, gangliosidosis as first, but lysosomal because of the
and it is, how old is this child? It's a slightly late. Sorry?
3-year-old.
Yeah, because they're beginning to show dentate changes as well, right? Yeah. Which is unusual as an early sign of. Okay.
Okay, Anas, we have two twins, both with similar phenotypes. So go ahead with the presentation.
So, twin one is a 4-year-old female child born to third-degree consanguineous marriage, first in birth order, with no postnatal or perinatal complications. The main issues were daily episodes of cluster seizures in the form of right focal, sometimes face, sometimes involving hand and limb, perioral chewing episodes. These were lasting for less than 3 minutes. Developmentally, so there's global development delay in both motor and cognitive milestones. Current motor age would be less than 7 months of age. She is non-verbal. Her hearing and vision is good. On examination, there's 48.5 centimeter head circumference. The central hypotonia, more axial than appendicular, with minimal weight bearing on made to stand. The twin 2 is of similar phenotype. 1 year, 6 months of present. The baby also had global development delay, both motor and cognitive, with seizures, cluster seizures, frequent cluster seizures, and central hypotonia. These are the clinical videos. Just minimal weight bearing on made to stand.
All right, so these two children had scans, I think 6 months apart. We'll look at twin one. Twin one at the age of 4 years. Some degree of atrophy in the frontal lobes in the cortical regions. Maybe some reduction in the posterior periodical white matter. The signal changes were, I didn't find any abnormalities in terms of signal changes in the supratemporal brain. But coming down to the brainstem, you can see that the central regions are demonstrating some degree of T2 hyperintensities. Coming down along the decussation fibers, the medial lemniscus, and the central tegmental tracts. Though they can be seen in physiological age group up to, I think, 2 years of age. This was a 4-year-old which had these abnormal symmetrical changes in central tegmental tracts and also in the brainstem midbrain tracts out there. And the midline sagittal sequence you can appreciate is a focal thinning around the posterior body and isthmus of the corpus callosum. The splenium also is slightly reduced in volume. And also the midbrain and the at least there's some degree of brainstem atrophy or hypoplasia, with again some Vermeer atrophy on the sagittal sequences. Cerebral hemisphere also demonstrate prominent folial spaces, so there's some degree of atrophy out there. On the diffusion-weighted sequences, these were the areas which demonstrated reversal on the ADCs. I don't have the ADCs, but yeah, these changes along the brainstem structures were again present on the diffusion-weighted sequences, which you saw on the T2-weighted sequences. Spectroscopy did not demonstrate any diagnostic peaks. At least we couldn't appreciate any significant lactate elevation and no other abnormal peaks in terms of the main peaks out there. And then we had twin 2. Twin 2 again has around, this was at age of 15 months, again some degree of supratemporal cortical atrophy. And the brainstem structures again have some hyperintensities out there. Now also there's involvement of the superior cerebellar peduncles, central tegmental tracts, and the Sag image also is pretty similar to what we've seen on twin 1, again thinning of the corpus callosum and also the brainstem structures. So both had almost similar imaging phenotypes, and also the clinical phenotype was matching. On diffusion again, the brainstem structures demonstrate some degree of restricted diffusion. We came up with a list of differentials, possible differentials of NKH, ITPA, mitochondrial tRNA disorders, pigopathies, channelopathies. So all of them were considered as possible differentials. Then the children were sent for genetics. Yeah, Anas.
Yeah. So both the children had the similar gene present in homozygous form. FT3 GAL gain of function mutation in exon 8, the seen in chromosome 1. It's showing autosomal recessive, though it was mentioned as and second BUS variant in the first sibling, but it was present in both the parents in heterozygous form. So based on the segregation studies as well as the clinical and radiological phenotype, it was a match.
All right. Then we looked at literature. Anas, do you agree that the the clinical phenotype matches?
Yes, sir. The phenotype of
yes.
Hypotonia. Yes.
All right. And only I could find only 2 papers with imaging, and only one had described changes of diffusion restriction in the periaqueductal posterior of the pons. No images were present. So yeah, slightly rarely described gene. So we'll hope if anyone has any further comments or similar cases.
We'll have to search the archives, Nihaal. It doesn't strike as something we've seen a lot of.
There are only 2 reports, so it's a pretty rare case, but yeah.
What is the function of the gene again?
I think it's a kind of a channelopathy, is that right? Or it's a congenital disorder of glycosylation, I think. Anas, any idea?
Need to review, sir.
And you have called this relevant as a mutation in this case.
Yeah, the genetics have called it a match.
Okay. So we need to look at the function, right?
Yeah. It comes under the developmental epileptic encephalopathy, but yeah.
Yeah. Got it.
All right. Next case, Prituja.
The next case is a 2.5 years old child with normal development. He had an alleged history of road traffic accident. Actually, no one noticed the accident, but they said that he had fallen from the sunroof of the car, but no witness. He developed loss of consciousness lasting for around 40 minutes after the incident, and then there was one episode of seizure in the form of uprolling of eyes and tonic and clonic movement lasting for around 2 to 3 minutes. On examination, his GCS was E3V2M5 and pupils bilateral reacting. And from the initial day, we noticed that there was paucity of movement in the left upper and lower limb, and multiple abrasions over the face and mandibular injury was present. During the hospital stay, the seizure episodes were persistent, and it was left focal seizure that was noted in the form of mouth twitching and clonic movements of the left hand. So after the seizure episodes, the encephalopathy gradually progressed, and at a time, the child was not able to recognize the parents, and he was not he was non-verbal. And we had done a scan initially. First, we did a CT scan, and after this event, the MRI was done subsequently. We'll be discussing about the MRI.
Yeah, so I have the first MRI on 28th of October. That's the date.
That was the first time.
Yeah. So then we have some areas of restricted diffusion out there. There's the right frontal region, subcortical cortical region, the left pedicillium region, the right temporal occipital lobe, demonstrating it. These areas of restricted diffusion. The hippocampus also has restricted diffusion out there. On the SWI sequences, we have some degrees of hemorrhage out there in the extraxonal regions, the right frontal parietal region along the falx cerebri, the left frontal region, coming down the pedicillium region out there, Sylvian fissure, and also the right temporal lobe has the subdural hemorrhage, a thin line of subdural hemorrhage. The temporal leaflets also has subdural hemorrhage out there. Angio and I think angio neck and brain was done, which did not demonstrate any abnormality. The spinal cord did not demonstrate any injury or connections. So after this MRI, Prituja, what was the presentation?
So he continued to have seizures, and encephalopathy process was gradually progressive. As I mentioned earlier, he was verbalizing, but then he stopped verbalizing, and then he was not able to recognize the parents at all. And there was no tracking of whatever he was seeing. So we went ahead of doing the second MRI image to see the progression.
So, yeah, second MRI was done 3 days later, if I'm not mistaken. Okay, 4 days later.
And on the 1st of November.
Yeah. Now we have a progression in the cytotoxic edema, extensive abnormalities, now predominantly involving the white matter structures. As you can see on the diffusion ADC sequences, better appreciated white matter changes. The right hemisphere is more in comparison to the left. Corpus callosum also is involved now. The cortex is progressed anteriorly on the right side, but predominant white matter progression more on the right side, and also left side has some changes of diffusion. I think ALE-RD was mentioned on the report as a possibility of the second image. So the question was post-traumatic ALE-RD, is that a phenomenon? Is that right, Pithja?
Yes, this was ALD followed by the trauma that was present.
And no hypoxia, if I'm not mistaken.
No, sir.
Okay, I'll open the case.
We had reviewed the literature to see if there were any cases reported who had road traffic accident leading to ALE-RD. We found that there was a case that was reported who had fall from a very short height, 2 meters height, and then he had this features of ALE-RD that was found in the MRI, similar to our case.
Dr. Udani, I see you raise your hand.
Yeah, thanks. I was a little late, but anyways, my question is that is it possible that this is a status that it changes? He had trauma, he had hemorrhage, he had a clear-cut subdural, blood. Then he gets a status epilepticus going on for a while, and these could be ictal or post-ictal changes. And I think that could sometimes, mimic AARD. Actually, AARD is a very difficult diagnosis to buy because basically there are two types. One is with the Rolandic area sparing, perirolandic, and the other one is diffuse. And if you look at, there are many conditions which can give rise to those kind of changes. So I'm always a little uncertain about this.
Got it.
When was the trauma, Nihaal, timeline-wise?
Pithja?
Just 2 days before the first scan.
So 20, yeah. This is 2 days later.
Yes.
2 days later. Because there is also this whole entity of a delayed, what's it called? Delayed.
DHP.
Yeah, exactly. It's more symmetrical than bilateral, but I mean, I quite agree with Dr. Udani's thinking as well. If this kid is having seizures, it could be related to that in itself. Rather than labeling it as an alert, I think we should look at possible etiology, right? Irrespective of whatever this is, in terms of outcomes, we still can't say if this is going to resolve fully or be left with atrophy at the end of this process. Is Mahesh in the meeting? He's the doyen of this, right?
That's the thing is, alert also is again triggered by seizures, so that's also a post-ictal change.
Exactly. Right? Yeah, I think alert is more of a sign.
It has maybe more cortical involvement rather than white matter. Yeah, the cortex is all. I mean, you see the diffuse ADC at least.
No, I think the excitotoxicity related changes are very typically like this in the context of seizures as well.
Okay. Yeah, the only thing was ALRD also has seizure related change, so maybe the semantics has to be changed.
A remote possibility could be CACNA1A mutation. There are many patients reported they have a minor trauma followed by a dramatic encephalopathy.
Is that the same one with hemiplegic migraine again?
Yes.
Yeah.
The CACNA, I've seen 3 or 4 patients only, but they seem to be a very cortical swelling kind of phenomenon, and it's very unilateral when it presents acutely. By and large, you have cerebellar atrophy with those patients. And the mechanism of trauma here is very strong if he indeed fell off the top of the car, right?
Yep. So we term it as excitotoxic injury and not alert, post-ictal related.
All the hemorrhagic changes, particularly on the right side, go with the fact that the right side has been hit worse, isn't it?
Yeah.
All that.
Even Dr. Kampli's paper has mentioned traumatic brain injury as one of the causes, but very isolated cases of traumatic brain injury causing.
Yeah, there will be an overlay with that as a primary and then a delayed white matter change related to the trauma in itself.
Okay, yeah, I think we need to follow the case and see if there's any atrophy later on. Pituja, how is the child doing now? Still
He's
asymptomatic?
encephalopathic, not recognizing non-verbal, and positive movements of the left side, persistent.
On ventilation or?
Not on ventilation, saturation maintained in room air.
Sorry.
He's on a rehabilitation phase right now.
All right. Okay.
Thank you.
All right. Next case, Kirti, if you're there.
Yes. So this is a 1 month boy, was born of second degree consanguinity, and at 20 weeks of gestational, antenatal gestational age, at TIFA scan, he was noticed to have prominent bilateral ventricles of around 8 mm size. And the child was followed up after that with repeated scans at 6th month and 7th month of gestation. And it was found that the ventricle size was not significantly increasing. It was increasing by 1 mm like that. So it was decided that after the birth, then they'll do the scanning. Fetal MRI was not done. It was not advised. And after the birth, it would be done. This was managed elsewhere. And after birth, CT scan was done, CT and MRI was done, which will be discussed further.
Just to stop you there, Kirti, ventricle of 8 millimeters is mentioned.
Yeah, this is at the level of antrum, in which they
but usually 8
mention.
millimeters we don't consider it.
Yes, yes. So it was slightly, and maximum it had increased up to 10 by the end of 3rd trimester. So, and after that, the child was born. So immediately perinatal, there were no complications. Birth weight was slightly on the lower side, 2.3 kg, but cried at birth. And on neurological examination, head size was fine, 34 centimeter, term child with mild hypotonia and no hepatosplenomegaly.
Okay. We'll have a look at the images and get back to the follow-up. All right, so CT at what age? Any idea?
This was done at 15 days of age.
All right. Okay. The main findings here are you can see that the white matter is slightly hypodense, even for a neonate. The bilateral periventricular deep white matter are slightly hypodense, but the main findings are these punctate calcifications in the basal ganglia, the cortex there, and also some regions of the periventricular regions and the subcortical cortical regions around the posterior frontal lobes on both sides. Ventriculomegaly, not able to, we can't measure it, but slightly prominent. Yeah, so these are the main changes on the CT scan. Then an MRI was done. On the MRI, you can appreciate again, white matter is slightly more hyperintense for the age, slightly prominent lateral ventricles out there. There are subepidermal cysts along the inferior aspect of the frontal horns. White matter again, slightly ratified on the flare sequences. You have these temporal lobe cysts. Again, periventricular cystic changes along the temporal horns. The axal sections, you can appreciate that the brainstem is reduced in volume, better appreciate on the SAGs on the next slides. These are 5 millimeter slice sequences. Maybe over here there is some simplified gyration, but not pachygyria in terms, there's no cortical thickening. Other than that, I cannot appreciate any malformations per se. Yeah, I'm not sure we can term this as polygyria in the frontal lobes, the basic frontal lobes, and simplified gyration gyral pattern in the frontal lobes. Yeah, temporal lobe cysts. And the midline sagittal sequence, you have thinning of the corpus callosum, severely hypoplastic brainstem, and also slightly reduced vermis. Given the imaging findings, concentrating on the individual features, subepidermal cysts can be seen in a spectrum of disorders. Paroxysmal is most common, but can also be seen in these various other conditions. Then we concentrate on temporal lobe cysts, as we have discussed in the earlier case. Interferonopathies can be one of the differentials causing them. CMV can be seen, can also cause them typically. mitochondrial disorders, RNAs, T2 encephalopathies, vanishing white matter disorders, and RMND1, again, a mitochondrial disorder, can cause these spectrum of conditions of the temporal lobe cysts. Classifications with these abnormal white matter changes. Again, these are the differentials: cocaine syndrome, CMV, more common in the periventricular region and subcortical regions than the basal ganglia. Interferonopathies like cardiogutries can have these body calcification in the basal ganglia and the white matter structures. There's a paper which Dr. Mankad was a part of, and again, they have mentioned the algorithmic approach for calcification. And our case had predominant white matter changes, and these are differentials for calcifications with the white matter abnormalities. We're dealing with interferonopathies, cocaine syndromes, CMVs as the main differentials.
So when the paper was written, RNA set 2 was not considered as an interferonopathy, but it is in the spectrum, which is probably what this will turn out to be, right?
Yeah. So yeah, Kirti, you
Yes.
can.
So we thought about CMV and congenital torch infections. Though torch for the child, IgG was positive, which was not significant. None of the IgMs were positive, so that's not significant. CMV PCR, it was done twice outside, and it was negative. And rest of the usual workup like calcium, parathormone, all those things were all negative. So we were thinking that it would be mostly genetic, ICARD, RNA, to these conditions.
So again, these are from the same paper and pretty similar images to what was seen in our case. So yeah, thinking of interferonopathies as a prime differential.
Okay. So planning for genetics. Next step would be planning for genetics.
When you say planning for genetics, what kind of test would you do?
Whole exome sequencing.
Will that pick up these subtle things, small things?
I think it should be able to. Yes, that's what I.
Reason is, are we doing interferon signatures before all that?
No, I guess we are rather sending whole exome directly. Yeah.
Okay.
Reason primarily,
Sorry, Dr. Yeah.
The reason primarily is because it's very difficult to get CSF interferon studies in India. We can get CSF pleocytosis like Sarbani says, yes, but that actually, at this early age, you probably would get, but in the later part of EGS, it goes away. And the interferon, unfortunately, I don't think anybody is doing it reliably in India.
I get it totally. Now, I just wanted to understand a little more about genetic testing myself, whether, when we say whole exome, are all these entities covered, or is it like hitting everything with a big bazooka, basically?
Yeah, Dr. Vivek has mentioned they do it at PDI.
Yeah.
JAK inhibitors are useful for treatment. Yeah. Question from Prabjot: what is the earliest state
interesting question. Yeah.
I think calcification
I'm yet to make an diagnosis of this, but calcification can be present quite early, Prabjot.
Okay, Dr. Vivek has started 2 patients on JAK inhibitors. Kirti, maybe you want to take a note of that.
Okay. So ruxolitinib has been tried?
Yes. And something with B also has been tried. I can't remember.
There's one, tinib only, yes. Ruxolitinib and the other one.
Problem is it would help very much if given very early, and once it progresses, it doesn't help.
Okay. Role of antivirals, sir. There has been also some people have used antivirals, acyclovir and these things are tried.
I don't think so.
Okay.
Kirti, get back to us with the gene.
Yes. Thank you very much.
And yeah, over to our last case, Dr. Sarbani, if you're there.
Yeah, hi Nihaal. So this 3-month-old baby, this 3-month-old baby girl, non-consanguineous, nothing perinatal. First episode at 1.5 months of age, left focal seizures, upper limb jerks, and at that time she was evaluated elsewhere. And at that time, she had no fever, nothing else, only isolated left upper limb seizures. So first baby, non-consanguinity, nothing in the perinatal period, gaining weight, feeding well. First time at 1.5 months of age, left upper limb focal seizures. At that time, the first MRI was done. Nihaal, you have the video of that MRI.
I have propped up the images. I had a diffusion and ST2, but I think the main findings are on the diffusion. I think it is slightly pixelated, but you can appreciate that there are areas of restricted diffusion along the right pericilium region, temporal lobe, parietal lobe. So predominant right hemispheric abnormalities and also edema along the corpus callosum, the posterior segments of the corpus callosum, possibly in the anterior segment too. But yeah, predominant changes were on the right side of diffusion changes. The T2s demonstrate the same findings. So these are the only two sequences I had. And post that, I think.
Yes, at that time she was treated with anti-epileptics. They had also given her low molecular weight heparin there for a few days. And then she was discharged. Normocephalic and nothing else at that time. So then this again 1 month later. So now it's 2.5 months, almost 3 months. And she comes with irritability for 1 day, followed by generalized seizures with desaturation requiring mechanical ventilation. So she had to be ventilated and she was resuscitated and stabilizing the ABC. And once the ventilation was up and gradually she was stabilized, we started noticing that she doesn't have too much of right hemibody movement. There was a lot of left-sided purposeless movement going on and a left-sided staring going on. So now, previously left focal seizures now reduced right hemibody movement and persistent left-sided staring and left hemibody purposeless movements. She had undergone the routine investigation, the CBC, the LFTs, the renal functions, the echo, the USG, and everything was fine. And that's when the second MRI comes up.
All right, second MRI, diffusion scans are again now on the contractile side. There's almost hemispheric excitotoxic injury involving the entire left hemisphere. Now the corpus callosum also involved the entire corpus callosum. There are some acute changes also in the right frontal lobe, which were not there previously. And coming down inferiorly, the brainstem, the left half of the midbrain and the pons also demonstrates the cytotoxic edema. On the T2 various sequences, you can appreciate the significant gliosis and encephalomalacia on the right hemisphere. Better demonstrated on the flare sequences. You can see that there is almost hemispheric volume loss, and the acute changes or subacute, early subacute changes on the left hemisphere now. SWI did not demonstrate any major findings out there. Then I think we had a post contrast. I think there's predominant glial enhancement on the left hemisphere. And on the MRA, these are the MIP images. You have these focal stenosis along the terminal segments of the ICAs, the proximal segments of the middle cerebral arteries and the anterior cerebral arteries. The neck vessels, the right vertebral artery was significantly reduced in caliber. I have source images out here. Again, demonstrating reduced caliber of the vertebral artery. So yeah, I think the main question was, Dr. Sarvani, if you want to just pose the question to the panelists.
Right. So she underwent a CSF study also, which was normal. And she underwent an EEG and which did not show anything very ictal going on there. Just the slowing significant on the left side and a little attenuation on the right side. So on 3-month-old baby at 1 month interval, both the hemispheres affected one by one. I think, of course, genetic vasculopathies are the mainstay here, or are we thinking, am I missing something, or what do we think of?
I think Prabjot has raised the query of FACNA1 mutation. As Dr. Mangal has mentioned, that can be a possibility.
So what clues will be for a genetic vasculopathy in this MR angio? I mean, are there any clues to say whether, of course, it doesn't, the age is too soon to be an acquired disease. So directly for the whole exome sequencing, go for the whole exome sequencing for the genetic vasculopathy, or are we missing something, or Could this still be
could you
something?
Could you tell us what are the findings on the MR angio? It's a little.
The angio, there's stenosis of the terminal ICAs. Also,
I mean, I understand that it's
and also the middle cerebral arteries, anterior cerebral arteries, and the right vertebral arteries also demonstrate reduced flow. So multiple areas of
So anterior as well as posterior circulation is stenosed and hardly any perfusion. I mean, of course, the perfusion study is not there, but hardly any blood flow.
I think the first scan we don't have, I mean, the angios, but yeah, the second scan, these are the main.
Can it be moya? I understand the collaterals are not very well seen, but the quality of the angio is not great.
Yeah, I mean, it can later on form collaterals if it's a progressive vasculopathy.
No, but usually by the time it presents, there's usually some degree of collaterals because it happens over time. But
this was only 1 month period, I think.
Yeah, the interval is 1 month and the baby is 3-month-old.
So the question is, can it be a genetic condition resulting in a Moya-Moya syndrome? Is that right, Dr. Udani? Or just a Moya-Moya pattern?
There's the Moya-Moyas I've seen very early in life are usually because of genetic reasons.
Yeah. So Moya-Moya like syndrome kind of cases.
So probably we should just go ahead with the whole exome sequencing. In the meanwhile, manage her conservatively, of course.
I think you should do some better vascular imaging.
Yes. I think that's fine.
The MR is not really telling you much, and if nothing, at least do a CT angiogram, which will be much better than this MR. What's happening with the vertebral? There are problems there as well, right? Is that what you're trying to show?
The right vertebral is again showing reduced flow.
Okay.
And
at the end of this, it'll be useful to screen the heart for possible cardioembolic phenomena before we get genetics and all that.
Normal, yeah, so 2D echo normal, USG KOV normal, nothing in the renal.
I mean, again, CACNA1A, none of us have seen a large cohort. I mean, the alternating syndromes, this is quite strong and severe, if you agree. What's happening with the white blood cells? Is that normal?
Yes, normal.
Okay.
A little low, I thought, yeah.
Yeah, 3,300, I agree. Slightly low, yeah.
Okay, so from our perspective, we would like to see some better vascular imaging. And Nihaal, I wanted to, if you have the full data set, see if what is looking acute had some old injury as well on the same side, or is it completely switched from one side to the other? You will need the T2 and flare for all that. Because I was wondering whether there was centrally a little more other things going on.
We had a similar patient, sorry.
No, go for it.
We had a similar patient in Wadia Hospital. Anybody there from Wadia Hospital?
Sorry?
Shilpa Kulkarni. I remember one patient they had, which was, it was one side and the second side. Exactly like this picture was. And there was an interval of about a couple of months in between. I can't remember what the diagnosis finally turned out to be. But I'll get back to you on that.
The right side has some acute abnormalities, at least over here, the frontal lobe. You can see some diffusion changes. But
yeah,
predominantly it has shifted to the other side.
And yeah, okay. And look at the brainstem. It's a straight line cutting across on one side.
So most of
us do a
think...
CT angio now. Is that the next contrast CT angio? I mean, yeah, so that should be.
Yeah, we should, because we don't know what we. If anything heroic has to be tried, we need better vascular imaging, right?
Sure. So the radiologist is on board and he's right now attending. So I'm sure he'll go ahead and do it.
Because the time of flight is slightly limited. I mean, the CT angio is slightly better.
I understand.
And Sarvani, there are no neurocutaneous manifestations, right?
No neurocutaneous markers, no. So thank you. Yeah, I'll go ahead with the better vascular imaging. I mean, CT angio.
Yeah.
And
Then we
I
can
have also ordered the genetics for genetic vasculopathies, including genetic moema. Thank you so much.
All right, thank you. And yeah, I think that is our last case. Before closing the session, maybe Dr.
Is anyone in India? Sorry, Nihaal. Is anyone in India doing bypass? Because this patient is basically collapsing their perfusion on both sides now.
Yes, you're right, and that's the reason that I wanted more inputs, that whether we should be aggressive in her case. In any case, they are going to meet the neurosurgeon who usually does the very good bypass.
Sarvesh had mentioned Dr. Paritosh Pandey from Manipal, Bangalore, who does bypass.
Yeah, well, bypass in the sense you mean direct revascularization, because that's usually done in older patients.
Right.
Indirect is done very commonly. It's done by.
I'm just thinking, yeah, because this is not a standard alternating syndrome kind of situation where it's not leaving much sequela. This is like glyosing the brain basically wherever it hits, right?
Yeah.
And yeah, even for that, you will still need better vascular imaging, and I would do an intracranial as well as the neck angiogram.
Sure. Yeah, they are seeing the surgeon next week to consider the indirect bypass. Yes.
This brain is already very atrophic. Do you
Yes,
really
in a month's
expect
time.
that this will be somehow reversible or remain like this?
It's not reversible, but we don't want further damage, right? We don't know what we're dealing with at the moment, though.
Yeah, but an operation at 4 months is not without complications, is it?
Yeah. Very technically challenging, I'm sure.
4 months.
Question of genetics has been raised. So yeah, ACTA1 data, I think as Dr. Sarbani has mentioned, that they are sending for genetics. So
yes.
But data, does it cause large vessel vasculitis like this?
No.
Yeah, more hemorrhagic and more small vessel kind of changes on the parenchyma.
Okay.
And also skin manifestations, I think, at time of presentation.
And the ACTA mutation with the vessels are quite different. I mean,
They're more straight in the and they usually don't cause such significant infarcts in the brain. Or
Yeah.
Any role of steroids I haven't given.
No point. I mean, the only reason you would consider is we think it's some sort of autoimmune or immune vasculitis.
Infective, yeah. I mean, I don't know. Yeah.
I don't know.
Post-infectious or something.
yeah, Dr. Vivek has mentioned low WBC is viral process precipitating these changes. Possibility.
So I'm just managing her conservatively. They're seeing the surgeon next week for the indirect bypass, and I've ordered the genetics. Yes.
Yeah. Okay.
Thank you.
Thank you very much. And
thank you, everybody.
The last case, Dr. Mankad, or you want to? All right. So in a couple of weeks' time, we have this been part 2 program. It's the leveling up program. We're on 44 talks with the speakers all over the world. So hope many of you will register for the program. The last call for registration is on 5th of November. You can scan the code over here for registration, or you can visit the website to follow the registration process. It will be on the 17th and 18th of November, Friday and Saturday. Those who have not attended part 1 can also attend part 2. So you're welcome to attend the course. We'll meet on November 17th, the evening after the first day of the sprint. So kindly send your cases by 14th of November. Yeah, thank you very much.
Thank you.
And see you in 2 weeks' time.
Last case is a puzzle, right, at 4 months.
Yeah.
We say genetic stroke, but none of these, many of these are not really concluded on.
Child also had, Is that only vascular, or is it part of epilepsy? I mean, the seizure causing the changes too?
It's too much gliosis for seizure, and again 4 months, and now the fact that it's flipped
No,
to the other side.
The second scan, the entire hemisphere is. I've not seen an entire hemisphere be impacted.
Yeah, I feel like showing this case to people around, like in the stroke services here, but I don't know whether they will have any more ideas.
I can send you the case. I have the entire files. I mean, the entire icons. Yeah.
This graphical demarcation is strange. Like, yes, send me the case. I will see if Vijaya Ganeshan might be around or somebody.
All right. Okay.
Things are getting more and more complex.
So I think the Wadi Hospital case had Moya 6 genetic cases with bilateral strokes after 1 month gap.
At what age?
At what age, Dr. Sindhu? Can you put it up in the chat?
4 months is early for anything, right?
At 4 months and 5 months. Yeah.
Kish, we had a child with a stroke, a Moya stroke at 15 days. And the child currently is 7 years, because before the parents could be counseled for revascularization, child was 3 months, and she is in a persistent vegetative state.
And how are we calling this Moya genetic syndrome? We don't have the phenotype of Moya, at least on the vascular imaging yet.
In the sense, if there's a progressive vasculopathy,
yeah,
with early stage revascularization is still not started, or whatever the mechanism of this genetic thing would be.
Okay. So earlier than late, we should definitely baseline the vascular imaging correctly then. And at this age, MR angiogram will not be high yield. Even CT angiogram will not be great, but at least much better than MR angiogram.
All right then. Yeah, we'll see you in 2 weeks' time at SPIN and later on at our case sessions.